Good morning, everyone, and thank you very much for joining this special webinar session where we're going to talk today about identifying and managing asthmatic symptoms in very young children. So we're going to look at this often underreported topic of asthmatic symptoms, and particular wheeze, in children under the age of 7. So joining us today are a number of experts who will explain why, as professionals in the healthcare field, we should all be mindful of both the prevalence of wheeze in this cohort, but also importantly, the challenges caregivers can face in identifying wheeze in children that are at an age where they cannot communicate clearly to express how they're feeling. So we'll explore how accurate and early identification can drive better outcomes from patients and the consequences if wheeze is left undetected. So firstly, we'll hear from Dr. Sarah Jarvis, who has over 30 years experience working as an NHS GP, and she'll share her experience of managing these symptoms in young children. We'll also hear from Professor Wim van Ouderen, a noted expert in the paediatric respiratory field, and he will explore the clinical relevance of early detection of wheeze. And then finally, my colleague John Paul Eckhout will introduce a solution to the challenges of wheeze detection in young children. So the subjects that we're covering in our conversation today can also be revisited in an e-paper that's being published by On One Healthcare. And the information in this e-paper is based on evidence and insights from a number of sources, including an original literature review on wheeze detection by On One Healthcare, a series of consumer and medical research papers that have been created by OMRON, and also information from a Freedom of Information request to the NHS about the challenges of managing asthma in young children within the NHS. So today's webinar, you may have noticed in the system, is being recorded. We expect that the webinar, we target the webinar to be 60 minutes long, and within that we'll have time for around 10 minutes of question and answers at the end of the session. So you should be able to see within the Zoom window the Q&A button. Please do feel free to tap on the Q&A button and ask your questions, and we will try to respond at the end of the webinar. If we're not able to answer all of the questions within the time available, we will make sure that we do follow up on all of the questions after the session, and we'll respond to the participants with those responses. So with those logistics out of the way, I would like to invite Dr. Sarah Jarvis, GP and author of 6 books, including the popular Children's Health for Dummies, and a resident doctor for various TV, radio and print media, and a clinical director at patient.info, to share her views and experiences on identifying and managing childhood wheezing. So Sarah, over to you.
Well, thank you very much indeed. As you have so kindly pointed out, you have outed me as someone with over 30 years experience as a GP. Actually, I've got 34 years experience as a doctor, because I became a GP the day I qualified as a GP. And during my GP training, of course, one of my jobs was a paediatric job. And I was a partner for 27 years in the same inner city practice. Those of you looking at me will realize that I qualified when I was 3. Now, it's a huge issue. It is an enormous issue at any time of year, particularly, of course, at this time of year. We have seen very gratifying levels of uptake this year in the flu vaccination among children, particularly 2 to 3-year-olds, between 45 and 49% in 2 and 3-year-olds respectively, or 3 and 2-year-olds this year for flu. But of course, flu and COVID indeed are not the only conditions in town. And unfortunately for children, viral urtes are part of the way, of course, that they develop immunity to infection in later life. And so often with viral urtes comes wheezing. But of course, if you have asthma, it's not just an upper respiratory tract infection, an urte, which gives rise to wheezing. So an awful lot of these children will get wheezy at some point, more in winter, but not by any means exclusively. Overall, we estimate about 1 in 5 infants wheeze at some point during their infancy, and by the time they reach the age of 6, so 0 to 5-year-olds, at least 2 in 5, so at least 40% of children have had at least 1 episode of wheezing. Why is that important? Well, let's just have a little look. If we look at the next slide, please. If we're diagnosing asthma in an adult, we would use objective measures. And briefly, I'll touch on those later. But the point we have here, this is the SIGN BTS guidance, the British Thoracic Society and Scottish Intercollegiate Network guidance, which really is our Bible. And it's one of the few guidances where I've always used it more than I have used NICE in terms of making my decisions, largely because it was around a long time before NICE was. But this is the latest iteration from last year. And they make a very important point. The diagnosis of asthma in children is based on a recognition of characteristic patterns of respiratory symptoms, signs and test results. But of course, in adults, the signs and test results are important. In children, those test results are effectively impossible to obtain because the children can't do the tests. But it's interesting that they make the point that even in adults, tests influence the probability of asthma, but they do not provide a diagnosis. And of course, what we are predominantly looking for in asthma is wheeze, perhaps slightly more nuanced in children, but wheeze is still undoubtedly the single most important symptom and the commonest symptom indeed of asthma in children. Why is it so relevant? Because, as I say, children can't take lung function tests, and that means that wheezing really is the diagnostic index. And because it's the most common symptom of asthma in children, if you have a child who has the right pattern and who has the right probability, and I'll come on to some of the factors that determine what your likelihood of asthma is if you're examining a child for the first time or they're presenting for the first time, it is likely to be wheeze that kind of clinches the diagnosis. And there's no question that while 40% of children have at least one episode of wheezing by the time they reach the age of 6, among those a significant minority are going to have asthma. 1 in 11 children, we estimate, has asthma. So if we move on, what we're looking at here are the possible symptoms. And as I say, wheeze is the single most common one. But Paul referred to the fact that a lot of the children we're going to be looking at are children who really cannot vocalize what's going on. They may talk about a tummy ache or rub their tummy or their chest rather than saying that their chest feels tight or that they feel wheezy. Cough is really important, and particularly in children, a nocturnal cough, a cough just at night when the child is entirely well, or an exercise-related cough is perhaps more likely and certainly would point you in the direction of a possible diagnosis of asthma. Whereas with children who have viral upper respiratory tract infections, they will get cough that is both day and night when they have an infection. But in the interim, they will often or almost always be free of cough. Now, given that the average child, especially if they're perhaps going to nursery, can get up to 12 viral upper respiratory tract infections a year, a lot of those, in fact, the majority of those during the winter, I have to say, as a parent and as a GP, I have great sympathy with parents who say, but my child is coughing all the time because it feels as if one comes upon another. But during the summer months, of course, then they will very often not be coughing. Breathlessness is also very important, and if we think about our definitions of breathlessness, of course they vary according to the NICE guidance. An amber flag, a child who is significantly breathless if they're over 12 months is breathing more than 40 times per minute. If they're between 6 and 12 months is breathing more than 50 times per minute. But regardless of age, in a child under 5, breathing more than 60 times per minute is a red flag. But also using a lot of their body, and we see this in adults, say older adults with COPD. They do this sort of splinting where they hold on in order to keep their body, keep their rib cage stable, and they may purse their lips in order to get breathing out. But with a child, you're more looking for what we call recession. So in other words, instead of the tummy naturally going in when you breathe, it goes out, going out when you breathe, rather, it gets sucked in, and the space between the ribs gets sucked in as if they're trying to suck their entire rib cage in when they breathe in. That's them using their accessory muscles. And you can also have flaring of the nostrils, the so-called ali nasi. Those are some of the features that we would look out for in a child who was breathless for any cause for asthma or otherwise. Next slide, please. If we think then about whether or not it is asthma, then these are the sort of things that I'm going to be looking at in terms of being as a GP, in terms of the likelihood. Is it a high, an intermediate or low likelihood that this wheezy child in front of me has got asthma? Well, firstly, have they got a family history? It's a really, really important factor, and it's not just asthma. There's eczema and there's hay fever. So we know that the presence of those factors will include atopy, and it's probably the single most clearly defined risk factor for asthma in children. The strongest link, interestingly, is the mother being allergic, so asthma, eczema, or hay fever. That's a really important risk factor for the development of childhood asthma, but also for recurrent wheezing that persists during childhood. Then we've got age. Now, it's really interesting, actually, that the earlier the child is seen to be wheezing, the better you are, if you like. So the natural history, the first time they ever wheezed, if they wheezed under the age of 2, and the earlier under the age of 2, the better, the more likely it is that this is not asthma. So if we look at these cohort studies where we look at patients and we follow them up, children who present before 2 years often become asymptomatic by mid-childhood, whereas children who develop wheeze after 2 years are much more likely to go on to develop asthma. In terms of gender, being male is a risk factor in pre-pubertal children, but interestingly, the roles are reversed later on, because if you're female, then actually you've got much more chance of continuing to have asthma symptoms as you transition from children into adulthood. So boys are much more likely to grow out of their asthma during adolescence if they are diagnosed with it. Perhaps not surprisingly, a child who is very, very wheezy a lot of the time is more likely to have asthma, but it also relates to the severity of that wheeze when they did present with it, how short of breath they were, how generally unwell they were with it, because an increased severity and an increased frequency of previous wheezing is associated with recurrent wheeze that persists into adolescence. And then finally, of course, abnormal lung function. Well, the problem with that is you cannot get a child to do spirometry. It's really pretty difficult to get many adults to do spirometry because it's really hard work. And even doing a peak flow or a fractional expired nitrous oxide level is really difficult to do in a child, a so-called pheno. So if we move on to the next slide. This is what we look at for diagnosis. So this is the SIGN BTS guidance. We'll be looking at the NICE guidance in just a moment. But if you look here in terms of high probability, I've just highlighted there wheeze heard by a health professional, and that is wheeze rather than what the parents depend on. And we'll come just before the end to explain just why it has to be wheeze heard by a health professional rather than wheeze reported by the parents, which increases the likelihood. And quite simply, it's because it is so unreliable, that history from the parents. So if they have got it, if they've got a high likelihood, rather, a high probability, then you make that diagnosis. But if we then move on to the next slide and just have a look at what we're seeing there in terms of how we treat it, what you're looking at there over on the left-hand side is that high probability of asthma. The problem is right in the middle, we've got assess the response objectively, lung function or a validated symptom score, and that simply isn't possible with a child, particularly a very small child, but actually to an extent in some children under 5. And the problem with that is that that means that it's very difficult, except on clinical grounds, to determine whether a child has asthma based on anything other than their symptoms. And of course, then we look at those red flags, which we'll touch on in a minute. But if you just produce that build now for me, please, just to remind it, in under 5s who can't undertake spirometry, the options are you start treatment and see if they get better, or you wait and see how they get on. So so-called watchful waiting is very different to saying to parents, go away. It's, look, we think there is a chance. We want you to keep an eye on this child. We want you to have a very low threshold for bringing your child back. But again, we'll come on in a minute to see that that threshold is something that may not be recognized by the parent. So if we move on to the next slide, if we may. Fractional exhaled nitric oxide has been the buzzword in general practice for the last few years because it's seen as the way of determining FeNO, as the way of making a really informed diagnosis, much more reliable than serial peak flows, which lots of patients are not terribly good at doing. And what we see here is that if you can get a FeNO level at age 4, then that correlates closely with being more severely unwell with asthma between the ages of 5 and 8. So a higher likelihood of wheezing, a higher instance of steroid use, and more likely to be diagnosed by a doctor with asthma by the age of 7. But if we look at what NICE says, next slide, please, what we will see is that they point out there that in over 17s, it's one thing, yep, go for it, do it. Otherwise, we need to think seriously in younger children at what we should be doing. Next slide, please. I'll rush through these last ones. Just to remind you, I've already said that in children, we go largely on the speed with which they're breathing. I've already explained the grunting, the recession, both under your rib cage and between your ribs, being drowsy, having episodes where you're not breathing, having very pale or blue skin. No parent wants their child to be in that position, and no doctor, I can assure you, wants to see a child brought into them. But if we just then move on to my last slide, and this will remind you why so often as a GP I do see that. Children under 5 who have asthmatic symptoms are much more likely to require urgent healthcare than other ages. And in fact, asthma exacerbations kill 3 people a day in the UK, but 53% of children report having had an asthma exacerbation within the previous year. And that, I think, is largely down to the fact that their parents do not know when to ramp up treatment. So there's a tendency to do one of 2 things. Either you over-treat the child, or more often in my experience, you're terribly worried about the side effects of medication on your child and you tend to leave it till too late. And I think this is a really important finding. 60%, even when they were shown a child on a video who's having a wheeze, could not identify that wheeze. And yet, more than 4 or 5 of them said they'd got reasonable levels of confidence in identifying it. And if you then consider that more than half of parents and children disagree on the presence of wheeze in consultations, that means that either I've got to work really hard to convince my parents that they don't need to worry about little Johnny, or I need to explain to them that they brought their child in and for all the right reasons, that child is in extremis. So I'm going to hand back now to Paul Stevens, and he's going to take us through some of the options to diagnose wheeze.
Thank you, Sarah. Yeah, some really interesting insights there on the pathway for diagnosis, and of course the challenges in young children, particularly children under 5. I think that important statistic that 1 in 11 children are estimated to have asthma really demonstrates the size of the challenge. And as you were showing in your last slide there, the importance of wheeze detection and the challenges that parents face is a key subject that needs to be addressed. And in my section here now, I'd just like to talk a little bit about those challenges and how through the research that we've done as Omron and the literature that's out there from other researchers that have sized this issue and identified some of the reasons for that kind of disconnect between parental understanding and the clinician detection of wheeze. So if we could move to the next slide, please. So of course, firstly is the question, well what is a wheeze? And it may sound like a basic question, but interestingly, the word for wheeze doesn't exist in many languages. So the description of the sound needs to be used, but we're lucky in English that we can say wheeze and at least explain to parents specifically what that means. And the wheeze is a continuous and coarse whistling sound, but obviously can be quite easily confused by parents with other kind of heavy breathing sounds, for example, after exercise or if they have a heavy cold. So that characteristic whistling of the wheeze is really what parents need to look out for. And this is caused by the narrowing of the respiratory tree. So the asthma causes an inflammation in in the breathing tubes, and that is then you get the forced air and you get that whistling. So physiologically, that contraction of the airways is the start of the asthma attack, and that's where we start to hear the wheeze coming. As Sarah mentioned, it's the most common symptom in children under 5 years old, but parents are not good at identifying. We've already seen that statistic, that in one study on a video, 60% of parents were unable to recognize that wheezing sound. So it really kind of sets up that challenge that parents have, because in order to support that diagnosis, that watchful waiting, it's really important to have that accurate and early identification of wheeze. So if we can move to the next slide. Yeah, thank you. So we know that parents struggle to identify wheeze, but why is that? Well, the wheezes don't always sound the same. They can be mixed with other sounds, particularly if the child has a cough or cold symptoms at the same time. Young children may not be able to speak yet, or they may be able to speak but not able to verbalize what they're feeling. So that makes it challenging for parents to really understand the situation. And we've spoken to many parents who have that conflict in them. For example, if their child seems to be breathing heavily or maybe wheezing, but of course the child doesn't want to even express that, because then they will not be allowed to go outside and play. So there's a conflict in the child not wanting to communicate the condition, and the parent having to navigate those challenges and really understand what's going on. And that creates the emotional stress and challenge for a parent as well. So many parents have told us that the most important thing for them with their child, if they may have asthma or they've been diagnosed with asthma, is that they want them to be able to lead the same life as their friends and to be able to do all the activities that their friends are doing. So that emotional challenge of saying, well, is now the time when I should stop my child from going outside of playing, or do I need to tell them to stay in and rest? That's a really difficult moment for a parent, and that creates anxiety around, are they detecting the symptoms properly? Are they thinking about the right symptoms? But of course, if parents don't detect those symptoms early enough, then that delay can lead to a worsening of the condition. And unfortunately, in many cases, it does lead to emergency situations, so hospitalization or visit to an emergency room. So there's one example from an NHS trust from our Freedom of Information request that reported over 500 cases in the last 3 years where the child's admission for asthmatic symptoms was actually the first clinical diagnosis of asthma. So most likely those children had displayed some symptoms prior to that kind of extreme event, but with the challenge for parents to really pick up on those symptoms and to communicate those well, that potentially could have led to some of those events from becoming severe. So if we could move to the next slide, please. So there is a disconnect between the perceived condition for parents and the reality. So often parents and clinicians disagree on the presence of wheeze. In one study that was shown actually that 55% of the time there was a disagreement between parents and clinicians about the presence of wheeze. So that creates a clear challenge that if children under 5, wheeze is one of the primary ways to be able to diagnose or treat a child with asthma, and one of the primary ways for parents to be able to realize that they need to react. That disconnect between the parent's perception and the clinician's perception creates a real challenge in that patient management, and particularly for those younger children that are not able to fully articulate their symptoms, and therefore they're relying on that perception of the parent in order to be able to address the condition properly. Next slide, please. So Wheeze plays a strong role in asthma management, as we've heard, and in fact in personal asthma action plans, which are recommended for all patients with asthma. Actually, Wheeze is one of the conditions where patients are advised that they need to use their reliever inhaler. So the reliever inhaler is used when patients are experiencing the symptoms of an attack, and it acts quickly to open the airways and in many cases to prevent that attack from worsening. So being able to detect the wheeze and to be able to act according to the personal asthma action plan is a really critical part of asthma self-management in a home environment. So if we look at those figures that we've touched on again, with 60% of parents not recognizing wheeze in that video study, and up to 40% of parents actually struggling to locate the fact that wheeze is a sound coming from the chest rather than the throat or the mouth, that kind of signals some of the challenges that the parents are facing. And those challenges are recognized by clinicians. So 80% of clinicians actually felt in one study that the parents were unable to identify wheezing correctly. And in a scenario where pre-diagnosis, the parental report of wheeze will be one of the data points that clinicians are using to make the judgment on treatment and management of those patients, that's clearly creating a challenge and a conflict between the perception of the parent and potentially the perception of the clinician. So this really reinforces the need for innovations and developments that can help to bridge this gap between parental perception and clinical judgment. So with that, and to talk give us a little bit more insight onto that clinical relevance of early identification of wheeze, I would like to hand over to Professor Dr. Wim van Ouderen from the Department of Pediatric Respiratory Diseases at Amsterdam University Medical Center. So over to you, Wim.
Okay, thank you very much. Thank you very much, Paul. Next slide, please. For centuries already, auscultation of the lungs, so listening to lung sounds, has played an important role in the diagnosis of lung diseases. And this became even more important. Next slide, please. With the invention of the stethoscope. Rene Le Neck, which was a French doctor who worked in Paris, invented the stethoscope. And more importantly, he wrote a book about auscultation and pointed out the most important thing about lung sounds, that it is much more difficult to describe them than to distinguish. Next slide, please. And this discussion actually lingered on until today. This is a position paper that was published in the New England Journal of Medicine in 2014 on fundamentals of lung auscultation. And they distinguished, of course, normal respiratory sounds and abnormal respiratory sounds, and wheeze is one of them. And Dr. Jarvis and Paul Stevens already explained the importance of wheeze, especially related to an underlying condition such as asthma. And in this paper, wheeze is described as a continuous high-pitched lung sound. Next slide, please. Wheeze is a lower respiratory tract symptom that is caused by any cause of airway narrowing. We know, and that was said already, that 1 in 3 children wheezes before their 3rd birthday, and only 40% of this group will develop asthma later in life. And that means that in the other 60% of the children, wheezing disappears and they don't suffer from asthma. The cumulative prevalence of wheeze at age 6 years is 50%, and preschool wheeze utilizes 0.50% of the total healthcare budget in the UK. Next slide, please. What is also important to know is that the differential diagnosis in preschool wheezing is different than the differential diagnosis of wheezing at age 6 and older. And what you can see here on the left side is these 4 conditions in blue that occur at young age, and all young parents will recognize it. On the first place, there is recurrent viral upper airway tract infections. And as a matter of fact, probably asthma exists already in these very young children, but it is hidden within the viral infection group. And the third is post-viral respiratory syncytial virus wheeze. And of course, there is wheezing due to exposure to cigarette smoking in the house. And then in gray, a long list of all rare conditions that may play a role, but most it's one of these 4 upper diseases. If we then go to the next differential diagnosis of wheezing at the age of 6 years and older, if a child wheezes, the biggest chance is that it is asthma. And of course, these more or less same group of rare underlying conditions may also play a role, but in all guidelines, it is stated that if a child has a history of wheezing and coughing and chest tightness, you can start with treatment. And if it doesn't work, then you go and look to the other more rare diseases. Next slide, please. Why is it important to identify a wheeze from very early stages? 40% of all wheezing preschoolers develops asthma, as have been told before. And recognition of wheeze, of real wheeze, offers the possibility of early maintenance treatment in order to prevent symptoms and to prevent early decline in lung function. 53% of children with asthma suffer from asthma attacks in the last year. And again here, recognition offers the possibility of prevention and early and optimal treatment. And then the last bullet point, doctors confirm preschool wheezing is likely a predictor of asthma later in life. And Dr. Jarvis already pointed in that direction. Next slide, please. Why is a wheeze difficult to identify? In the first place, they don't always sound the same. The sound of wheezing depends on the breath frequency and is obscured by other lung and throat sounds. And wheeze may be interpreted differently. And what you already have heard is that parents may describe any noisy breathing as wheezing. And there is a large discrepancy by the estimation whether it's wheeze or not between parents and doctors. There are a number of studies that underline this. One of the studies you have seen already from the group of Kane was published in the year 2000. They found a 55% disagreement between parents and physician assessments of wheezing children. And there are more studies, but I think there's another important study on the lower side of the slide. They found that lung function in children with physicians confirmed wheeze was significantly lower than lung function in children with only parental reported wheeze. And Dr. Jarvis already mentioned that lung function measurements in young children are not possible. That's not possible in a routine situation. In this study, they did that, and that's rather a difficult job to do. They did it in the research setting, and there they found that already on young age, lung function was lower when there was physician-confirmed wheeze, which indicates, of course, that the underlying condition is more severe. Next slide, please. It is important to recognize wheeze, and not recognizing a wheeze might result in the first place in undertreatment, resulting in unnecessary reduction of quality of life, frequent asthma attacks, hospital admissions, referral to pediatricians, and as a consequence of this, an increase in costs. And on the other side, overtreatment resulting in unnecessary misdiagnosis, side effects of treatment, and of course, again, an increase in cost. And all this makes it important that wheeze in young children should be recognized correctly. Thank you very much. Paul.
Thank you very much, Professor Van Alder. And I think really interesting to hear the long history of the recognition of wheeze as an issue going back more than 200 years. And still the importance of the detection of wheeze in the diagnosis and management of asthma. And I think interesting to reflect on the fact that in those 200 years, really the method for detection of wheeze has not really changed. Still using the stethoscope and the physician's trained ear.
Yeah.
So I think that's really interesting insights, and actually brings us on to our next speaker, Jean-Paul Eekhout, who is responsible for respiratory product development and a research expert at Omron Healthcare, who actually would like to bring some news in that area. So he's going to present a groundbreaking technology that's aimed at specifically identifying asthma symptoms or identifying wheeze in this young age group. So Jean-Paul, over to you.
Thank you very much, Paul. So yeah, my name is Jean-Paul Eekhout, and I work at Omron in the respiratory department, and I've been closely involved in the development and the launch of this exciting new product, which I'm really happy to introduce you. So in April of this year, after many years of research and development, Omron Healthcare introduced WeScan. And WeScan is the world's first automatic wheeze detection device from home use. And from the previous speakers, they have already explained to you in detail what is the importance of timely detection of wheezing. And we've also discussed the challenges that parents and caregivers are facing in the timely detection of a wheeze. Omron recognized those challenges, and as part of our global strategy to develop devices and services to prevent fatalities caused by asthma, we set out to develop a device which supports parents looking after their young children diagnosed with asthmatic symptoms. WeScan supports parents in the timely and correctly detection of a wheeze, allowing them to follow the treatment plan provided by their doctor. It's really important to point out that WeScan does not replace the role of the parent or the doctor. So WeScan is really positioned as a second opinion device, supporting parents who are in doubt or are in need of reassurance. This is particularly valid for very young children who cannot yet express themselves. So in this supportive role, WeScan provides relief to parents and their children. WeScan helps taking the guesswork out of wheeze detection. With this development, our ultimate goal has been to help parents improve asthma management with their young children. Improved adherence to treatment plans will improve quality of life and will reduce exacerbations, or worse, emergency hospital admissions. So Omron WeScan detects a wheeze with clinical accuracy. In a clinical study that was published in October 2020, WeScan showed 100% sensitivity and very close to 96% specificity compared to the judgment of trained physicians. So with such high level of accuracy, we are confident that WeScan will bring relief to many parents and caregivers responsible for the well-being of their asthmatic children or children diagnosed with asthmatic symptoms. I would now like to show you a short video which explains the functionality of WeScan. Next slide, please. Thank you. So I hope this short video has given you a good impression about the functionality of WeScan. And before we leave you, I would like to close with a couple of remarks. That is, of course, before the Q&A session. WeScan is not for all parents. WeScan is aimed at parents with young children diagnosed with asthmatic symptoms. And then in particular, those parents that have indicated that they have challenges with the timely detection of a wheeze, as already been discussed in previous presentations. And this is why we emphasize the role of the physician in making parents aware of WeScan as a supporting device. And naturally, WeScan is a CE marked device, and as such, it is a clinically validated device. It's also worth mentioning that WeScan is fully portable. It comes with a carry case, also supporting parents while on the go to catch a wheeze, to bring the peace of mind not only in the home but also in, when they're out and about. And let me close by stating that WeScan is super easy to use. In no more than 30 seconds, WeScan will tell you whether your child is wheezing or not. So thank you very much for your attention.
Thank you, Jean-Paul. I think really impressive device, and I've had the honor to be able to speak to many patients during the development of the device and to understand their personal stories and challenges of asthma management. And we heard almost unanimously from those patients about the value that a device such as this can provide them in their challenges of detecting and managing wheeze with their children. So it's really great to see that this device is now available and there to help parents. So we now have around 15 minutes where we'd be very happy as a panel to answer any questions that attendees have. So if you do have any questions, either to Dr. Jarvis, Professor Van Alderen, myself or Jean-Paul, please do feel free to add them to the Q&A chat session in the Zoom system, but we will and we will answer those as they come up. Perhaps in the meantime, while we wait for the questions to come in, a question to Dr. Jarvis or Professor Van Alderen. Are you seeing any increase in the number of patients displaying wheeze symptoms or being diagnosed with asthma over the last few years compared to the past, for example?
Schoolboy error. I hadn't unmuted myself. Absolutely no question in my mind that I'm seeing more children diagnosed with asthma, and there is evidence that the incidence is increasing now. It may well, at least in part, relate to pollution. I work in inner city London, and our pollution levels are not all that they should be. It's actually been quite interesting during COVID that I have probably seen children with fewer exacerbations because so many of them have been at home. And certainly during the first lockdown, we saw it sort of came towards the end of the winter, the beginning of the spring, and we were seeing fewer children. But interestingly, those that we did see were definitely more sick. And I think, of course, we were seeing fewer because they weren't spending so much time in contact with other children. We all know there was a very interesting paper that came out in the Lancet this summer talking about COVID and the impact on schools. We all know that there is this huge increase in the incidence in the attendance rate at A&E, in emergency attendance rates and so on in the first 2 to 3 weeks following the start of the new school year. And there's no question that the lockdown reduced that, but certainly what we did see during the lockdown is when parents did have children who had asthma, I think they were so terrified of bringing their child in or getting them anywhere near a hospital, because at the time, of course, we were not aware that the risk to children in terms of mortality from COVID was so much lower than we now know, that they really were waiting until their child was in extremis and hoping that it wasn't asthma.
Thank you. So really interesting. So on the one hand, that increasing trend of asthma symptoms, but then, well, I wouldn't call it a silver lining necessarily, but that impact of COVID and the lockdowns and the really kind of helping to demonstrate the link between the child's environment and the presence of asthmatic symptoms such as wheeze.
Exactly.
Thank you. And to Dr. Van Alderen, have you found in your experience that this disconnect between the language used by parents and clinicians about Wheeze is a challenge? Be interested to hear your experience.
It's definitely a challenge, and the problem is also that it's hard to say, well, I don't trust you, to the parents if they tell you that their child wheezes. That most of the cases when the child is brought to the doctor, the child doesn't wheeze, so you have to go for the answer of the parents. And I think what most doctors do is then believe them, and if it's worth enough, start treatment and hear the next time if it goes better. But that's, you know, then you come in the problems that I showed on my slides. It really is a problem. And some children are really severe and come into hospital and are admitted to hospital. But there are also a lot of children that never come to hospital. You never hear wheezing, and you don't know whether it was a correct diagnosis or not. Okay,
yeah, really challenging situation. I can imagine that balancing that relationship with the parents as well, as you say, in terms of telling them whether what they're hearing is true or not, it must be a significant challenge for a clinician.
It doesn't make friends, no.
So we have some questions in the chat around the WeScan itself. So I'm going to ask Jean-Paul to help us out with some of these. So first question from Ali Narat. How precisely does WeScan detect a child's wheeze, and what role does the advanced algorithm play in that?
Thank you. That's a great question. So the study that I've referred to in my part was done recently, or during last year. It was published in October. It showed that WeScan has a sensitivity of 100% and a specificity of nearly 96%, 95.7 to be accurate. And of course, the advanced algorithm plays a key role in that. During the development of WeScan, we've used actual wheezing sounds, feeding this into the algorithm to let the advanced algorithm identify this very specific signature of a wheeze in, let's say, the size of a body of a young child. So the two go hand in hand. The success of our advanced algorithm development has given us this high level of sensitivity and specificity.
Can I just add to that? If you've got a child, if you're worried about whether or not they need to come and see a GP, for instance, A, the fact that the specificity is so high, I think is really important. B, in terms of short-acting bronchodilators, parents are very, very worried about giving short-acting bronchodilators, but overall, frankly, they are extremely safe. At worst, they might cause the child to get quite jittery. So, for instance, if a child is extremely unwell with asthma and goes into hospital, we will give them, 20 puffs of salbutamol through a spacer, wait 5 minutes, and then give them another 10 puffs. So there's an awful lot. That's an awful lot of inhaled short-acting bronchodilator you can give. But certainly in terms of whether it's going to result in a child, if a child is really unwell or the parents are really concerned and they're continuing to diagnose wheeze, then we would expect them to be coming to see the GP. And as a GP, wheeze is not the only thing I'm going to be going on. I'm going to be looking at signs of recession, signs of respiratory distress, using a pulse oximeter to see what their oxygen levels are, and of course looking for recession and so on. So it's the likelihood of too much medication being given, I would say, is absolutely tiny.
Thank you, Dr. Jarvis. I think that's a really important point there. So it's better, in fact, for the parents to err on the safe side and to administer that reliever medication. And then if the detection is, or if they're detecting wheeze on multiple occasions, then indeed to go to the GP, but always to err on the side of safety in terms of giving the medication.
And one of the pieces of advice we always give to parents is that if they've given their child their reliever medication and they've still got symptoms, that is an indication they need to come and see the doctor.
Great, thank you. So the next question, actually another question from Ali. Why is WeScan only for use for children already diagnosed with asthma? So Jean-Paul, maybe you can pick up on that.
Yeah, right. Thank you. Yeah, I saw that question, and I realized that I think the way I formulated my sentences in my part, it is a device that detects a wheeze, but it's not a device that a parent should go out and buy just to see if the child is wheezing. I think the first port of call should still be their physician, should be their doctor, and I think we have no aspiration of either replacing the doctor or the parent's opinion about whether the child has asthma or not. And as these two topics are closely related, we believe that this product is best suited for those parents that have children that have been diagnosed with asthmatic symptoms and have also indicated that they are in need of the extra support. It would not certainly be our statement to say, well, if you are a young parent and you have a young child, go out and buy a WeScan and check if the child is wheezing. It's not that type of device. It really fits within the very specific condition your child may have or will have.
Thank you, Jean-Paul. And I think important to differentiate there between, for young children that may not be diagnosed with asthma but are being treated with medication for asthma-like symptoms such as wheeze and shortness of breath, where WeScan absolutely can help in that management pathway. And then, of course, in older children, when they're able to be diagnosed, then it can help with the detection there, but indeed not intended as a diagnostic tool for asthma, because as we've heard, there's many other symptoms and areas that need to be investigated before that diagnosis can be made.
This is a little bit in line with a question I see in the chat, where somebody asks, if a WeScan says my child is wheezing, does that mean they have asthma? No, it only means that the child is wheezing. And as a physician, you need to know the story behind it. So if a child is a recurrent wheezer, that's different than a child that suddenly wheezes and may have taken in a peanut that is in the lung. Wheezing means only there is in one way or another airway narrowing. And that's the only thing what wheezes shows. And the most prevalent thing are recurrent respiratory infections and asthma. But you certainly have always to think, what is the cause of this wheeze? And the story the parents tell you is probably the most important thing.
Thank you very much. Yeah, that's a great clarification. The next question, how sensitive is WeScan in contrast to other devices available on the market? I think again, one for you, Jean-Paul.
Yeah, I think to answer that question, it is. I mean, we have the specificity and sensitivity I've mentioned before, which is I think the highest we've seen. But I think WeScan is also, it's very, let's say, single-minded. It is very much aimed at this very specific symptom. There are other devices on the market, let's say the digital stethoscope devices, that serve more purposes. So I think in this particular case, the difference is really the focus on this very specific condition, and I think also the target audience we have in mind. So our device in this particular case for wheezing is very accurate. And that should not discount other devices on the market, but we really are focusing on this very particular case.
I think it's fair to say that I was impressed with the data, and with 100% sensitivity, you may get others which are as sensitive, but you're not going to get one that's more sensitive.
Right, thank you.
Thank you. Yeah. So we are running up to the end of time here. We have time, I think, for one more question, which I think is a question on false positives. So what is the possibility of having a false positive, and then what is the impact of giving medication to a child on the basis of that false positive?
So I think I've largely answered the comment about the impact of giving a child medication on that basis. If you've got a child where you're picking up wheeze, but the child is otherwise entirely well, and it's a false positive, and again, the data that I've seen suggests that in 97.5% of cases, there will not be false positives because it's very specific. So the specificity is 97.5%, which means that the false positive rate is only 2.5%, and that would be on a one-off basis. But again, I think as a parent, certainly if I've got a child and I'm with their parents and explaining to them, I would always be explaining to a parent that wheeze is not the only thing that you look for. If you've got a child who is running madly round the sitting room, is tearing down the Christmas decorations, is trying to climb up the tree and wants to clamber on your lap and chase the cat at the same time, then I do not recommend that parents be giving their child doses of inhaler unless they have any evidence of symptoms, and wheeze would be only one of them.
That's great. Thank you very much. I think that's really helpful advice for parents and really clear on how to manage that. So with that, actually, we've reached the end of our hour. I think it's been really interesting and informative for me to hear the views from you, Dr. Jarvis, and from you, Professor Van Alder, and we thank you very much for being a part of this discussion. And John Paul, thank you for your insights on the WeScan. Of course, if any of the audience have more questions, please do feel free to get in touch with us on the email address that's there on the slide. And lastly, just thank you to everyone who's joined the session. We appreciate you taking an hour to be with us. And yes, please do get in contact with us if you would like to learn any more.